Welcome, everyone. My name is Preston Fontenot. I'm the North American Sales Manager for NewSmile. So thank you for joining us for another exciting webinar tonight presented by NewSmile. We're thrilled to have you here as we dive into another really relative topic in pediatric dentistry, and that's going to be over bioceramics. As a leader here in pediatric dentistry solutions, NewSmile is dedicated to providing really cutting-edge materials and techniques that we are trying to enhance not only your clinical outcomes, but for patient care as well. Today, we're going to explore how bioceramics are reshaping the landscape of pediatric dentistry with their remarkable biocompatibility, sealing abilities, and the regenerative potential as well. Whether you're here for looking for more clinical success or just simply to expand your knowledge on this topic, you're in the right place this evening. So before I hand it over to Dr. Patrick Ruck, I do want to go over a few housekeeping rules. And first is going to be CE. I know everyone's interested in how to make sure they get their CE. So once you complete this webinar this evening, our events team will email you a survey. Once you complete the survey and email it back to our events team, they will email you the CE certificate. I just asked, it usually takes 24 to 48 hours for the team to respond back to you. So just give them a little bit of time. And then lastly is going to be for our questions for the presentation. The presentation is going to be about 45 minutes, and then we're going to reserve the last 15 minutes to answer any questions that you may have. So you feel free to type your questions in the Q&A chat box at the bottom, but I won't actually read the questions until the last 15 minutes or so. And then if you have any questions over our upcoming webinars, please feel free to go to newsmile.com. We list all of our upcoming webinars on there as well. And I will, sorry, getting a little tongue-tied there. I will go over how we get our CE again at the end of the presentation if you're just hopping on. But other than that, I'm going to go ahead and hand it over to Dr. Patrick Ruck.
Thanks, everyone. Just want to say thank you for having me. I usually listen to these, and I usually have an earbud in, and we're doing like tub time with the kids. For those of you on the East Coast, I know it's late. I'm usually fixing to go to bed soon, and those of you on the West Coast, I hope you had a great day at work too. I think this is a great relevant topic in our landscape right now. There's a lot of great materials, especially coming out of NewSmile, that are utilized and really changing what we're doing in pediatric dentistry and evolving what we can do with pulp therapy, indirect pulp therapy on both primary and permanent teeth. So these three pictures, this is something I do quite a lot. I call them my little pediatric core buildups of after I do my pulpotomies and then place my MTA, my NeoPUTTY, and then I usually cover it up with some type of bulk filled high viscosity glass ionomer cement. This is Equia Forte or anything that you'd like to use. So just one disclaimer. Let me go to the next slide. So NewSmile has provided some financial support for this presentation and materials for pediatric training and pediatric dentistry. Many images in this presentation are taken by fellow NewSmile clinicians or accredited. Anything that's not my pictures, I have who it's by and the doc that provided that image. It's usually one of my NewSmile buddies as well in our little group. So I want to say thank you to the NewSmile crew. I do have a few of these people that are left off, but NewSmile is one of those companies that I really have enjoyed working with as a practitioner because they always answer my questions. They always take feedback seriously. If there's a product you don't like or you're having issues with the product, you can always reach out to one of them, Preston or someone, and say, hey, I'm having this experience. They want you to be successful with their products, whether you're at a dental meeting or calling them or at one of the courses. They're just a really nice team. I've really enjoyed kind of being part of the new crew and learning and growing and kind of evolving these products. So this is a slide about me. I wouldn't be able to do any of this with my awesome wife, Magdalena. We have two little kids, and it's right now, it would be so feral at our house. There would be screaming, bath time. It would be wild. We have two kids, Caroline and Winston. I did my residency at Cincinnati Children's Hospital Medical Center, went to dental school at Virginia Commonwealth University, and I practiced for 4 years in the National Health Service Corps. I did 2 years out in Arizona in the Navajo reservation at Sohotza Medical Center, and then did another 2 years at the Eastern Band Cherokee, west of Asheville, North Carolina, and Cherokee, North Carolina. And then I've been at Cincinnati Children's now for about 5 years, full time. And then I work a day a week starting this July. Right now, it's been a few other days in private office at a local office here. And that's our Cincinnati Children's Hospital. So I'm not a big like aphorisms guy, but I do think, and these are from Peloton. Sorry, I'd say that it's a little dinky. But do things that you don't like. Do the things you don't like. That's what makes you special. Focus on what you're not good at and become good at those things. When you do the things that you know you are not good at, it forces you to be a better provider. And what I mean by that is we're all here, we're all taking these webinars. We all do CE to try something new, whether you're interested in adding a bioceramic or you just want to learn more about MTA-like products or things like that. It can be hard. There's always this uphill challenge when you're trying to introduce something new to your practice or your office or your program. And so I think we're here today because we're all interested in getting better at these products or introducing these products, whether you're using ferric sulfate or formic creosol and you just want to grow what you have available to your office. So this is Winston trying something new. He's our wild one, and I call this like baby CrossFit. So this is him at one of his first classes. He's getting jazzed. He's running around. Oh, and so Winston, that was his first class, so he was trying something new, and
It's good every
he
time.
was it's good. Yeah, he was totally fine. My wife was filming it because she's like, oh, this is really fun. This is so special. But it can be hard to learn something new and different in implementing it. And another thing I like to talk about is, we're all in practice, whether we have community members or other people that are down the street from us, people in our practice. If you're at a learning institution, other people, who are you learning from? Who's your mentor? Who's kind of pushing you to learn? I've learned so many things. These are all the wonderful people that kind of interact with New Smile and talk about their products, use their products. It's really a wonderful team of people that I've learned from. I've learned something from each one of these people that I have listed, whether it's a direct New Smile product or just something. Jeanette McLean's pretty much taught me everything about minimally invasive dentistry, and everyone on here has given me some kernel of advice or something that keeps evolving my interest in dentistry in general. So New Smile is a pretty rad company. One of their first products was that signature crown, and it's definitely evolved. I tell Preston that New Smile, and in my opinion, it's like the Brassler of pediatric dentistry. They're here to help us be better pediatric dentists and offer some pediatric dental solutions that make our job a little more exciting and fun and easier. And then this is kind of our overview. I put a little QR code for those who are interested. New Smile actually has a pretty rad YouTube channel that has all of these recorded webinars. That if you're interested in learning about other things, or sometimes maybe you have your earpiece in while you're doing something else, getting dinner ready if you're late at night, or putting the kids down or things like that, and you just want to go back and watch it. So what we're going to overview is talking about how we're going to use bioceramic materials in pediatric dentistry. An idea that we're going to thread is talking about the inflammatory process that leads to the development of tertiary dentin in both reparative and reactionary dentin, and then how that inflammatory process in reactionary and reparative tertiary dentin response influences our selection of what bioactive materials we need. And then finally, we're going to show some clinical uses of these products as well. So first, we're going to talk about our inflammatory and immune response in a reversible or irreversible pulpitis. We're talking about vital pulp therapy. So all of our diagnoses should potentially be a reversible pulpitis. And then we're also going to talk about how that directly relates to our use of bioactive materials and the difference between calcium hydroxide and hydrated calcium silicate-based materials. And then we're also going to talk about clinical indications as well. So first, we're going to kind of get into MTA-based liners and pulp therapies. So we're going to be differentiating two different products. Things that we use when we're close to the pulp and things that we use when we're dancing in the pulp. When we've done that, I call them BACs, big awesome cavities. You can switch the A word if you want to. That's well, now I said it so much now. The residents are like, Dr. Ruck, we got a BAC. And I'm like, ah, but that's just our code for like, you have a big, awesome cavity and you're doing that number occlusal and there's a huge pulp exposure. So hopefully some of these things will help us mitigate or navigate those things. So we're going to be talking about MTA-like products when we're close to the pulp, our baseliners, than when we're actually staring at the pulp. One of the reasons why I got really interested in this topic is when I came back to Cincinnati Children's, this is a publication that we did, I noticed that we were doing so many indirect pulp therapies when I was with the residents. When I was a resident, that's when Formo was still the fundamental pulp therapy medicament, and ferric was still kind of becoming the new it girl. But then there are those cases of facial cellulitis because of water contamination with ferric, and that's kind of fallen out of fashion in the guideline recommendations. And this is just looking at our indirect pulp therapy code and pulpotomy code. They totally 180'd, from when we started keeping this data from 2008. So that's what really got me kind of interested in seeing what products are available that were starting to influence us doing these more indirect pulp therapies. And then this is James Cole and Vineet out of Maryland, their publication, which I think is really kind of our authority in pediatric dentistry as far as our selections for medicaments. And this is just a flow chart. And in that lower left-hand corner, when you look at the vital pulp therapy, as we kind of thread that needle down, our MTA and biodentine-like products are what we should be using. And then under that is our formicreosol. A lower indication is our sodium hypochlorite, ZOE, ferric sulfate, and fully under that is calcium hydroxide. And I've met, again, the whole spectrum of people when I talk about this topic, and they'll say, well, I use ferric and I have good success, or I use this and I have good success. So you could, I'm advocating for you to, one, just follow the guidelines. If something's working for you, rock on. But you might want to think about other things that you can add to your armamentarium that could be very successful in certain clinical applications, and we'll talk about that as well. So we're going to next kind of phase into, well, how is our caries process a reversible pulpitis, and then if it goes farther, irreversible pulpitis, pulpal necrosis, an inflammatory process. So we're all kind of very familiar with our infected, affected dentin and how that carious process progresses. So the big question that we're going to look at is inflammation a prerequisite for pulpal healing? And when I was a resident, and sometimes we think dentistry is magic, like, oh, here's this paste we poop into a canal, and yeah, it works. How does formicreosol work? How does ferric sulfate work? How does MTA? How does NeoPUTTY work? Sometimes I just like, it's like the internet. I don't understand the internet or cell phones. It's just magic. I don't know. But it's really cool to understand the science behind this and how we pick these materials. So our pulp inflammation process, what happens is you have localized stem cells, or that are farther down the tooth, and then localized odontoblasts. In minor inflictions, those localized odontoblasts can start making reactionary dentin. And then in deeper insults, we can actually recruit stem cells and differentiate them, so pulp fibroblasts, and differentiate them into odontoblastic-like cells that come up from the root areas and help with producing things that are helpful in bone repair or remineralization. And those are the SPARC proteins, or osteonectin. What a cool word. Or things like the sibling family that are also responsible in bone matrix. So these fibroblasts, or odontoblastic cells, come up deeper and help with our reactionary and reparative dentin. So that's what we're going to kind of get into next. Is if we have a mild stimulus, we think about our reversible pulpitis, our caries, and that is going to have these more localized cells being recruited to make reactive dentin. And then our deeper localized pulp tissue destruction, when we're doing a pulpotomy, we have a pulp exposure, we are going to actually recruit cells that then differentiate into odontoblastic-like cells that help in that intense stimuli, that reparative dentin process. So let's look at our reactionary dentin. So this is going to be our subtle stimuli, such as caries, minor trauma, an operative procedure. So it's formed by those viable odontoblasts which deposit pre-dentin. So it's very similar in structure, physiologically similar to our dentin. So reparative dentin, so now we're thinking about, oh, we're really close to that pulp, microscopic pulpal exposure, things like that. So when the odontoblasts are more massively affected by severe trauma, invasive carious lesions, and noxious agent, those mesenchymal stem cells are recruited from deeper layers of the pulp and differentiate into odontoblasts in response to those odontogenic cues. So this reparative dentin is formed at a higher pace, and it's characteristically disorganized. And we're going to kind of get into those actual cells and why it's important for the product that we're putting over that exposed pulp tissue. So this is kind of that, remember that caries imbalance slide from Featherstone? That way, this is kind of like the pulpal imbalance slide. So in side A, we have our infection and inflammation imbalance for our regenerative, where in the earlier stages of the carious lesion, our inflammation and infection are at a relatively low levels, excuse me, and then can help promote and engage with reparative and regenerative mechanisms. So we get some localized release of trying to not over science it and over nerd it because I don't want to bore you guys with the hardcore science, but we get some localized recruitment that starts that reparative, that tertiary dentin, that reactionary dentin in those deeper areas. Now, as caries proliferates in slide B deeper down into those tubules and causing more inflammation, that's when we get that recruitment. And then we see increase in cytokine and chemokine complement section of our immune response. It's pretty rad. I didn't like it kind of blows your freaking mind that you have this little microcosm of inflammation and immune response just happening locally in our primary teeth pulps. I mean, in our irreversible pulpitis, these are all the things that are ongoing in all of the different actors that involve in that inflammatory process. So now we're going to start thinking about, well, how does that reaction or inflammatory process relate to the materials that we're selecting? And when we look at our traditional things that we've used, when I was in dental school, it was still, your dical, your calcium hydroxide products, Limelight, which is also a calcium hydroxide product. And I would argue Theracal LC is going to be in your di and tricalcium silicate or MTA-like products that has resin. And then one important thing when we're looking at MTA-like products, you don't tend to see this anymore. You can still sell this, but previously, like the original ProRoot formulations used bismuth oxide as its radiopaquing agent, and that's what would cause staining. When I was a resident and we used to do regenerative procedures, those teeth would look black, like SDF black. And so now you have tantalate, zirconium oxide as different radioopacers. So make sure when you're selecting a product, and NeoPUTTY it has tantalum in it, but when you're selecting a product, make sure it doesn't have bismuth oxide in it. But what I really want to talk about are the important factors that we think about for a bioactive material. One is going to be the pH value, and we'll talk about that as far as why that's important. You want something that's going to have a very alkaline pH. And NeoPUTTY definitely is competitive and has those great basic pHs. Similarly with our water sorption, you want a lot of these products start working when it absorbs moisture from the surrounding material, but you also don't want it to rinse out, like calcium hydroxide. And then two, you want a high level of calcium ion release. So when we're talking about levels of calcium ion, when you add things like resin to that product, it's really hard to discern. But our product like Limelight, which is a calcium hydroxide product, releases a very negligible amount of calcium. So if you're trying to select a product to use as an indirect pulp therapy, but you still want a high level of calcium release, you're going to select something that's more of a hydrated calcium silicate or MTA-like product. And then anytime that you add resin to something, so you have like your kind of pure uncuts, you have your NeoPUTTY and NeoPUTTY-like materials, and then we start adding resins to things like our Theracal LC or NeoLiner. So that kind of decreases the calcium output as well. So it just depends on the clinical situation that we find ourselves in. So kind of talked about the materials, and then we're going to circle back to that. But now I want to kind of parse out the indications for these specific procedures for an indirect pulp cap or a protective liner. And I feel like these kind of blend into kind of the differences where we're using a protective liner or an indirect pulp cap to not expose pulpal tissues, whether that's to line a deep preparation so we're not directly etching over it, or we're placing it over a non-exposed area of pulp tissue, but there could be blushing or there could be deeper portions where we're trying to place a biocompatible material to either stimulate tertiary dentin response or reactive dentin. And you want something that's going to be biological and biocompatible. Well, what is bioactivity? I feel like that word gets thrown a lot around in pediatric dentistry, bioactive, bioactive, bioactive. Pretty much bioactivity is defined as a medicament that mimics hydroxyapatite. So it allows for the in vivo formation of calcium phosphate. And so that is really kind of that definition of a biomaterial. So when we're thinking of that selection, what is needed in a biomaterial? So we talked about, indirect pulp caps, base liners. We've talked about calcium release, the alkalinity of a product, the amount of water absorption. And we've talked about the inflammatory process of pulp tissue and pulpal healing tertiary dentin, whether it's reactionary or reparative, as an immune response to localized or deeper trauma to the tissue. So calcium ions enhance the pulp cell proliferation and differentiation, and those are essential for that hard tissue mineralization. So the degree of calcium release has a dose-dependent effect on human dental pulp cell proliferation. So you want something that has a moderately high calcium release. The alkalinity of that material, one, allows it for an antimicrobial effect and also helps enhance the formation of our tertiary dentin, or the bridging to occur, which I'll show a clinical picture of that as well. And it also helps release tissue growth factors and enhances the formation of the tertiary dentin. So degree of calcium is important. Degree of calcium release is important. The alkalinity is important. Well, let's look at physical properties. You should have something that isn't so water soluble, because if it doesn't super dissolve in water, our solution, then it's going to help stick around and help form that new reparative dentin more quickly. So our water absorption, though, is essential for our ion release, but if it's excessive, we'll have voids under our restoration. And that's going to kind of walk us into the difference between MTA or hydrated calcium silicates or ditricalcium silicates or calcium hydroxide, like your DiCal products. So MTA versus calcium hydroxide. Calcium hydroxide has insufficient adherence to our dentinal walls. When it washes out and you get multiple tunnel defects in the induced dentinal bridges. I always tell clinicians, go ahead and throw away your DiCal. We all should really now kind of be evolving to use a ditricalcium silicate when we're in situations where you would have broken out the DiCal and Vitribond. The biocompatibility and sealing ability of MTA results from the dominant calcium ion release from where the materials react with phosphates in our tissue fluids and induces that hydroxyapatite formation. It does it at a much higher level than calcium hydroxide and is better at doing that than calcium hydroxide. So that layer that the MTA produces forms a better chemical seal in between the dentinal walls. It's not an actual bonding process, but it does a much better job than calcium hydroxide. It doesn't wash out. One thing that you see in calcium hydroxide studies is it has a high degree of washout. MTA is also less cytotoxic when compared to calcium hydroxide. If you look at apples to oranges studies of calcium hydroxide versus MTA in vital pulp therapy, shows that it's actually less toxic. And so you're getting less reactionary pulpal information than calcium hydroxide. The application of MTA also has an effect upon the regeneration potential of dental pulp because, again, it's alkalinity, it's calcium ion release, all the things we talked about on its previous slide influences those tissue growth factors from the pulpal cells. So this factor helps those progenitor cells that we talked about in the deeper areas. Remember, those stem cells get recruited up, and those progenitor cells migration to the material pulp interface. So it stimulates their differentiation into odontoblastic cells that secrete that reparative dentin. So MTA is checking all of our boxes here. We have something that has a high alkalinity, something that has a high degree of calcium release, and is doing a good job at directing that inflammatory process that we discussed earlier. Rad. Cool, man. So our protective liners, now we're kind of circling back to that. And what are our objectives for those? Well, we're going to want to put these in our friends that have deep carious lesions, again, where we're avoiding the pulp and we're not trying to expose pulpal tissues. So our clinical applications of NeoLiner or NeoLiner-like product is going to be on our indirect pulp caps as in a cavity liner. And I think a great question people ask is, well, when do I consider something a cavity liner, or when do I consider something an indirect pulp cap? Sometimes we place a liner because we don't want to, if you're using a total etch system, or you're using something that has a hydrophilic resin mono or resin mono and you're worried about cytotoxicity, sometimes we'll lay that down on the floor, and then that way we won't etch and bond directly over that area that's really close to pulp tissue. Or we're using an indirect pulp cap where we're losing some affected dentin. If you remember that caries progression in the first slide, we have that more leathery affected dentin where we're trying to stimulate that reparative dentin formation. I think one thing that I like to discuss and talk to people about is when you're doing a procedure like an indirect pulp cap, we have to make sure focally we have 360-degree happy dentin around that area. Maybe it might be this high mesial pulp horn that we have in the picture here. And that way we have to have that intimate relation to the caries and also the underlying pulp tissues underneath. We can't have a severe amount of decay in between the calcium hydroxide or the MTA or ditricalcium silicate material and the pulp, because then that medicament's not really stimulating that formation that we need to. So now we're going to be talking about the IFUs for NeoLiner and the benefits of those products. So NeoLiner is used for a cavity liner and indirect pulp capping. You do not use this in anywhere where you have a direct pulpal exposure because it has resin in it. So TheraCal does say that you can use it as a direct pulp capping agent, but we'll talk about that in a second. And then Limelight is indicated as our cavity liner and base material. So just kind of a refresher, Limelight is our calcium hydroxide-like product. NeoLiner, TheraCal are going to be our MTA-like products. And then remember how we talked about the degree of calcium release? So this is internal data showing that NeoLiner actually has a higher degree of calcium release. And that's important when we talk about our ability to form tertiary dentin, so our reactionary reparative dentin. So that's what's really super rad about this product, is we're getting that higher degree of calcium release compared to its competitors, and it's also has an MTA or ditricalcium silicate in it. So you're getting the benefits of a di and tricalcium silicate being blended into something that we could like cure. I'm just going to go back and look at the IFUs. So what's really important when you're using this product is having adequate isolation. And it comes with two different tips, the 22 gauge, or excuse me, it comes with the 22 gauge. And what I was trying to say, I apologize, is more directed areas. I use that smaller 22 gauge tip, which is like a sealant tip. But if you need to add it in a larger area of material, I would use like an etch tip. And we'll talk about that when we talk about clinical cases. And you're just use it a millimeter or less. So less than a millimeter thick. Think about our periodontal probe. And I really think it applies really nicely. I know I get so frustrated when I'm applying Vitribond and I'm trying, and it goes all over and it's messy. I really love this product because it goes right where you want it to. And if I need more of an application, I could put on a larger tip, like a flowable tip or an etching tip. And if I really need it to be directed, I can put on that smaller sealant tip. So when looking at a product like TheraCal that says it can be used for direct pulp capping, so this is a study where they looked at bioinductive materials in direct and indirect pulp capping. Well, because TheraCal or those type of products have a bis-GMA-like resin monomer, were found to be more cytotoxic. So I wouldn't recommend anything that has resin in it to be used on direct pulping agents. Even if the IFU is approved for it, I would you would probably see your success rate not as high as actually putting a pure MTA-like product on this. So these products, the NeoLiner is really for base liner and indirect pulp capping only. So the NeoLiner features and benefits that we kind of summarize. It's easy to place. It is bioactive. It has our MTA or di and tricalcium silicate product. So you get a higher calcium release compared to its combination. And it also has that alkalinized pH that we talked about. So it increases our hydroxyapatite formation, and it has bactericidal effects. And then remember, where you can use it as a liner, or we can use it as an indirect pulp cap to help against sensitivity, so we're not directly etching all those areas. It's water soluble. It's insoluble and moisture tolerant. So again, those are some of the benefits that we talked about. And it's compatible with all etching and bonding techniques, and it's radio opaque. So let's go over some clinical cases. So this is a primary cuspid. And what I wanted to show is after we remove decay, we have this little friend here of some localized reparative dentin or a reactionary dentin that we didn't want to etch. Because you can think about when you think about failures or things in primary teeth or sensitivity, there was once pulp tissue there and it kind of healed itself over. And so we put our Neo liner, and that's what I love about this. It just goes right where you want it to. And you don't need a ton. You want to make sure all of your restorative margins are super clean and clear. And then we isolate and build our really awesome super restoration that, again, is going to protect that pulpal area because we have that high degree of calcium ion release. So that's an instance where I would use the smaller tip. And let's look at a case where we'd probably use a larger tip. So this is an amalgam replacement in a young friend. So here's our caries excavation and our amalgam removal, and then our isolation. So again, we just this is when I'd probably use it more as a liner. I'm putting a really nice thin layer over where I would presume the pulp to be, and then I have clean margins everywhere. So if I'm using a total etch system or a selective etch system, but a bonding agent that has a lower pH that's slightly acidic, I am not worried that I'm causing that pulpal sensitivity. And I'm also getting the benefits of the calcium ion release, the alkalinity. So it's you're just knocking it out of the park with these things, and we can provide a super awesome restoration for this friend. And then here's another example where, these are the cases that when you see the x-ray, I'm like praying to Jesus, everyone, because I was just like, man, this is not going to be this is going to be a tough customer case. And again, we always want to make sure we get our diagnosis right in these, right? Make sure the patient's asymptomatic. Make sure we're pulp testing these teeth. We want to make sure we're in that reversible pulpitis stage where we don't think there's so much pulpal inflammation that we have to go farther after we do our removal. So the upper right-hand picture here is that area of leathery affected dentin that we left, and we put a really nice layer of NeoLiner down, have amazing, clean margins around this preparation, and then here's our final restoration. This is me using my intraoral camera, so I apologize. And then here's another case. This is a case where we did band stabilization. That's a Dr. Paul Bond trick. I've also heard it called the Palmetto technique, but I learned this again from Dr. Paul Bond, and we use it a lot in our program here, and I use it a lot in practice too. So here is our removal, and I'm more concerned about this really high mesial pulp horn friend that we have here. And you could see some reparative dentin and already some sclerotic dentin as well. So we put a really nice layer of our NeoLiner down, and then cementing an orthodontic band to preserve the occlusal table and the original occlusal anatomy of that tooth. These are called smooth bands. And then we cement it, and then I usually fill this up with a high viscosity glass ionomer cement. And if I need to make it more stable, I'll take like a 330 and prep some of that back and put a composite over it. This is a great indication. This is from Dr. Matt Lucero. And I just thought it was a great example of when you can use this in the anterior tooth. Again, so you would use a smaller tip. Those other cases where it was a wider area, I would use an etchant tip or something longer. And what I love about this is you're not trying to mess around with the Dical or the Vitron. You just put that NeoLiner on, you cure it, make sure you have perfect isolation like Dr. Lucero has here, etch, bond, restore. It just helps simplify that restorative process. And then this is just another case from Dr. Lucero. I like this because it's really demonstrating the the radio opacity of the material. So it's showing up on your radiographs. This is Dr. Lucero using it in an indirect situation. So now we're going to talk about vital pulp therapy. So our first discussion was we didn't have a pulp exposure. We were either using a baseliner or we were trying to leave some affected dentin to avoid a pulp exposure. So we either have a mechanical or caries pulp exposure, vital pulp, absence of spontaneous pain. The diagnosis is going to be really important in these friends. We have hemostasis with a cotton pellet. We have no apical or focal radiolucencies. We have an absence of swelling, abscess, or fistula. The tooth is restorable, and we have a lot of root remaining, and there's no ectopic eruption of the 6-year molar, kind of taking out one of our roots. So when we say MTA, what is a hydraulic calcium silicate? So MTA is kind of like turned into Kleenex now. I think the appropriate word is a hydraulic calcium silicate or di and tricalcium silicates. So these are cements that are used in dentistry for vital pulp therapies. And again, we kind of talked about the properties of them are more favorable to calcium hydroxide because of the alkalinity, the high release of calcium ions. And so the main characteristic of this reaction is we have these dicalcium and tricalcium silicates that are introduced with water. So NeoPUTTY is anhydrous. The water has been taken out. And when we place it inside of a pulp tooth or a tooth that had pulp therapy on it, the moisture from that area helps the setting reaction. And then once it's mixed, resulting in a calcium silicate hydrate, and then you get a release of the calcium hydroxide as a byproduct of its reaction. And so with NeoPUTTY, what's really rad is there are these really cool, don't throw these away, because when I talk to people about NeoPUTTY, they're like, but it's really expensive or so on and so forth thing. And I go, yeah, but there's you can be really prescriptive in how you use it. One is using these little guides that come in everything of NeoPUTTY, especially if you have staff. I remember when I would use mixing MTA products like NeoMTA, NeoMTA2, Angelus. I remember at one time I had a staff member mix like a sandwich of MTA, and it was just like, oh, that's a lot. That was the whole bottle. So I really like this prescriptive dosing guide. It's not left-handed friendly. I was sassing Preston for that one because I was trying to show someone how cool it was, and I was holding it with my left hand, and I was like, oh. But it really tells you if they're doing a Shrek primary first molar. It's very accurate. And remember, every kid's tooth is different. And another thing, there's a lot of different ways to deliver MTA. I actually roll mine up in a little ball, and this is how I do all of my MTA products versus using a carrier, which I think you need a little bit of waste in that as well. So I usually dispense it. And I take this on the back of my glove. I'll take it on a paper pad and roll it. And that just makes it so much easier to dispense. You just take it out with paper plates, put it right in, and then I'll condense with a cotton pellet, or I'll condense it with a micro brush. But I think it's such a more economical way than trying to use those amalgam condensers and having material stuck in there. And so its indications for use is any type of vital pulp exposure. So this is kind of my workflow. I don't use on primary teeth sodium hypochlorite or chlorhexidine. I just use a moist or dry cotton pellet that you can use. If you look at Vinit's in Jim Cole's papers, it doesn't really matter if you put one of those medicaments, if you want to use like 3% sodium hypochlorite or not Paradex, but an actual endodontic solution of chlorhexidine, you would be okay to do that. So I do my occlusal reductions, access, and I'm putting my cotton pellet in, and I have some video examples of, well, how much bleeding is too much bleeding, and then I'll apply my NeoPUTTY, condense it in with the cotton pellet. This is two pumps of Vitribon. You could also use any glass ionomer cement. I always like to completely fill my preparations, and I have a great picture in a different lecture why. If that crown comes off or restoration comes off, I want that pulpotomy to be fully occluded and obtunded. I want to make sure that's not going to come out. If the child were ever to lose the crown, it's just going to look just like this, and I can just take a new crown, spend it off. If we were eating Starburst or something like that. How much bleeding is too much bleeding? If you take those cotton pellets out and it's still welling up with heme, that is too much bleeding. That inflammation is still way farther down the root where we have tissue tags or things like that. And you're going to see, we're going to suction this, and this little pan bear is going to fill right up with blood. And I think that's why some people, when they switch from former creosol or ferric sulfate, former creosol is a slow death. You're not going to see it fail overnight. Um, but you're going to get that wonky resorption that we tend to see in those issues, where NTA seals so much better. But I think it's just the flexibility isn't as what we're used to for former Cresol. So there is a little bit of a learning curve. This would be like an adequate amount of heat pulling in the tooth, in my opinion, as far as kind of what's appropriate. And then here's a little clinical example. And what I'd like to show in some of these, I have a goofy YouTube channel if you guys are interested in watching this
Hey,
video.
Dr.
It's
Ruck,
it just
just letting you
yeah.
know, it seems like when you're playing the video and talking, it's a little bit
Mhm.
of a lag. So as soon as you stop, the video
Oh,
stops. So it's going, just giving you a heads up on that. So
I shall be quiet then.
good.
I will also preface, I'm not good at making these videos. I'm not meant to be an influencer. But it's just showing how I typically, this is my workflow for using NeoPUTTY in these deeper carious lesions.
It seems to be okay now. So
Oh, okay, thank you. And that's our refined. And what I like about these products is there's such a wide range of things we could do with them. Things that I used to send to the endodontist, this was a large caries with a caries pulp exposure on a friend that we just did a direct pulp cap in. And one thing I'll preface with direct pulp caps or partial pulpotomies is you really need to make sure all the caries is removed. If you're attempting a partial pulpotomy and direct pulp cap, a permanent molar pulpotomy, you really have to make sure all of that decay or that caries process has been removed out of that tooth. The research, I think, still supports that. But this was a friend who had a premolar exposure that we just did a partial pulpotomy, a Schweck pulpotomy with, and a nice composite restoration. And she is still asymptomatic. I think that PA is from 6 months after the procedure. Her tooth is testing vital. It's just amazing what we can do with these things with minimally invasive endodontics. Here's another friend that I saw where we did a pulpotomy on the tooth, and then again a buildup with Equia forte. And then the idea is the continued epexogenesis of these teeth. We're doing so many. This allows you to do so many rad things on our friends that probably couldn't afford a root canal or maybe not be super cooperative for a full endodontic therapy, but as a pediatric dentist, you could definitely do a pulpotomy on that tooth. And then the process for this pulpotomies on permanent teeth are still exactly the same what you would do in a primary tooth. We need good hemostasis. The only thing I change is with the American Association of Endodontics, I'll use a 3% sodium hypochlorite pellet in that tooth prior to for about 5 minutes and make sure we have adequate good hemostasis. And then this is just a clinical case that I wanted to show where I chose MTA. Again, how close are you to the pulp? What do you want? If you have resin in it, I'm using this more in an effort because I felt like I was so close to the pulp. In reality, looking at the X-ray, clinically, I felt I was very close, that I needed pure MTA because I was worried about a potential microscopic exposure that I wasn't seeing. So I went ahead and did the full shebang, cleaning it with sodium hypochlorite, putting my MTA down. And this tooth was eventually going to have a crown with a general dentist. And I know we're running short on time, so we'll just get through our cases. This is a great example from Dr. Matt Lucero of a perfect time and indication to do a partial pulpotomy on these teeth. High mesial pulp horn. Take all the caries out, that bleeding area, put our sodium hypochlorite in, expand the area to about 2 millimeters, about the depth of the 245 burr, get great hemostasis. If that's still bleeding, we need to take more of that out. Place your MTA material, and then Dr. Lucero put neoliner over that, and you build a nice restoration that's well sealed. This is a great example of a young man who re-traumatized his teeth that we did a pulpotomy on. So you can really appreciate that actual calcific bridge that was formed. And then that pulp was still vital. So I just did another pulpotomy in that tooth, sealed it with a high viscosity glass ionomer cement. And then you can really appreciate that calcific bridge. And then I usually try to do about like 245, 330 depth of a burr. And then here are nice restorations. We're saving these friends from needing to get root canal therapy. Similar with trauma, um, this is an example where we did a fragment reattachment with a young friend as well. And again, I love these products because they really stay where you put them. And I think that's really wonderful when we're doing these more minimally invasive procedures like a fragment reattachment, or we're trying to do minimally invasive endodontics like a Schweck pulpotomy, partial pulpotomy. And then there's kind of our final for this friend. And this will be my last little funny story. This is Waffles and Maple Syrup, our two dogs. I call them that. Is Maple sits on top of Waffles, and he really does this. They still do it. We had a little direct pulp exposure. So what did I do? I did some tabletop dentistry at home, and I did a direct pulp cap with NeoPUTTY. I cleaned it with sodium hypochlorite, put NeoPUTTY on it, did little bandages with Equia Forte. He kept biting it off, but I kept replacing it. And this is about 3 or 4 years later. That tooth is still there. It's asymptomatic. So they do work. I don't recommend, I am not a licensed veterinarian. But that was just, I was like, I don't want to take the tooth out, man. And then again, we can use it for anterior pulpotomies as well. Same procedure, get your caries out. We have great hemostasis on this tooth. I put my MTA down. I do my little high viscosity glass ionomer cement core buildup, and then I want to look down the tooth. I still have a great amount of ferrule, and I'm going to restore that. And my restorative height is similar to this unaffected tooth as well. And then here's another clinical example where I did 3 anterior pulpotomies with NeoPUTTY, high viscosity core buildups. And then we have a nice final restoration that was similar to, again, I always try to replicate whatever was there. That's what I want it to look like. I'm not trying to save teeth that we probably shouldn't save. I want to make sure we have a similar restorative height. And then the last case, again, deeper caries pulp exposures. I have a little video of this. This is, again, I'm trying to show what does hemostasis look like when you're switching from these NTA products. A little blood pooling in the orifice. And then we have our MTA, our little high viscosity glass ionomer cement cores. Refined our preparations, and that's our final. I went and got this cement. I'm always amazed. I'm really tenacious about getting rid of cement, and I'm always amazed how much cement is sometimes left over. I'm usually pretty wild about that. And I think I'm a little over, I apologize, but I tried to get a lot of different clinical examples so everyone out there in TV land can appreciate really rad stuff. So many things we're doing with this that we weren't able to do 10 years ago. It blows my freaking mind. Thank you
No,
guys for your time. I know it's late, and I appreciate everyone being on here.
no, you're good, Dr. Ruck. You're perfect on time. It's 7:50, so perfect. Yeah, we'll open it up for questions. It looks like we have 4 or 5 in there, and it looks like you have some fans already from the beginning. Go Cincy. The presentation is absolutely brilliant. Thank you so much for the exciting information. So yeah, I got
Thanks,
some.
everyone. I really appreciate that.
But starting off for the first couple questions we have, the first one I have is for indirect pulp cap, do we want to place neoliner before the conditioner etching? As it says, I saw something that said bond before neoliner. Wouldn't a bond layer interfere with the calcium transfer?
That's a great question. Yeah. So and we'll have to double check. See, this is great. We'll have to maybe double check the IFUs, Preston, to make sure
Yeah.
it doesn't say that. No, you can etch bond over your neoliner. So I always place, whether you're using cavity conditioner, if you're using a high viscosity glass ionomer cement, or you're using like a weak primer adhesive like the Fuji no rinse conditioner, or you're just using a total etch system or a no etch system. No, yeah, I would put your neoliner down first, make sure you're adequately isolated. So after you set up your matrix system or whatever you're doing, and then etch bond and restore over that. Yeah, you can etch over this material. But we'll double check the IFU for that. I always place my neoliner first because you're quite correct. Yeah, we don't want to put any, if we're really close to pulp, any hydrophilic or unpolymerized resin monomer that could potentially cause some cytotoxicity. If there's microexposure, we're worried that we're that close to the pulp. Yeah, great question.
Awesome. The next one I have is, can you explain the Paul Bond evaluation method with the steps and material? And then
Oh
what
yeah. The band. Yeah, rad. No
And then the
problem.
second part of that question is, what indication do you use the space maintainer molar band for?
Yeah, so these are called smooth bands, and you can here, let me go back. Yeah, it's a great question. You can get them from multiple different I think we have, I think 3M, I think some other, we have an orthodontist here as well, so I kind of borrowed her stuff sometimes. But I think you can get, I think we have the 3Ms, they're called smooth bands or seamless bands. So indications, teeth with molar hypomineralization, teeth where you are worried about restoring the natural form and function of that. The nice thing about those seamless bands is that they have the correct occlusal dimensions versus like if you were using a Tafelmeyer or something else. So what I like to do is I anesthetize, I'll seat that band, and now I have a nice restorative matrix. Now, this can kind of go two different ways. You can go ahead and cement the band and then remove the excess cement around your restorative margins, and or you can leave the band on, restore and cement it afterwards. I tend to end up cementing the band, removing the cement where I need to. These bands are a little thicker too, so if you prep on them, not the end of the world. You're not going to perforate it because they have a little bit more thickness than the Toffenmeyer band. And then I'm going to make sure I finish my preparation. And on these hypoplastic teeth, or maybe teeth that are not fully erupted, but we still want to maintain and isolate. Think about those upper sixes, that number 3 or number 14 that has a large distal occlusal buccal lesion. Well, now I have great isolation because I have that cemented band, and I'm going to do pulp therapy or whatever I need to, and I still have great isolation, and I'm going to etch, bond, restore. And then when that tooth comes in more, you can maybe transition that to a stainless steel crown if you have to, or if it's a patient of record, you're pretty comfortable changing that band out, you're saving that wonderful restorative margin. My wife's a general dentist, and she sassed me a little bit because she had to take off an SSC that I did and put on a crown. Well, that patient needed 2 appointments to get the gums and the margins. The gingival margins were so inflamed because that thing's been there forever. So it's just a nice way to transition your friends into a general dentist for that future full coverage restoration. That's a great question. Yeah, but seamless bands, and you can fill it up with a high viscosity glass ionomer cement like Equiforte, or if you can use a restorative material of your choice like a resin.
Okay, cool.
And the
Next,
cement, Fujisem too. Sorry, I apologize.
I know
Any
you
any sort of high viscosity glass ionomer cement will work. Fujisem Ortho, any of your orthodontic cements.
perfect. And just letting everyone know, if feel free to put your questions in. If we run out of time, we will still answer your questions. We'll just do it offline. I'll have via email. I have Dr. Ruck, and that's when we'll correspond via email. So feel free. We'll probably wrap up right around 8:03, 8:04. But don't hesitate to have any questions or submit your questions. All right, the next one I have, Dr. Ruck, is, are you concerned about heme left in your pulpotomy prep causing internal resorption?
Learned about heme. Say that again. Sorry.
Are you concerned about heme left in your pulpotomy prep causing internal resorption?
No, so great. I think what I'm wondering if you're getting at. So the answer is no. You actually need a little bit because these are moisture activated materials, and it is a immunological response. So you actually do need a little bit of pooling. You don't want to see two perfectly clotted things, and that's why I don't use any other medicament like ferric sulfate or in a primary tooth. I will use sodium hypochlorite in a permanent tooth. But no, one of the greatest things you can see sometimes is pulpal canal obliteration. It just depends how much inflammation was there. I think sometimes if we tried to do a pulpotomy on a tooth that maybe, again, diagnosis had an irreversible pulpitis, so like this friend that's bleeding like crazy, well, that inflammatory process is already starting. So if I were to just put my MTA down on that and seal it, well, my inflammation is already so far apical that I probably am just going to get some resorption because that inflammatory process and those mediators are farther down the apex of the tooth. But in those clinical situations where we have great isolation, where there really is just a little bit of pulling there, no, I'm not worried about internal resorption. It bonds so well, and that tertiary dentin forms so well, and the research is kind of supporting that even in permanent teeth. when we're doing these permanent molar pulpotomies. It's really all about the diagnosis, you making sure that you're not misinterpreting it, and we really are in an irreversible situation.
Perfect. Do you sterilize your cotton pellets for phlebotomies? And can you review what you
Ooh.
can soak them in again?
Oh, that's a good. This is where you want to might check your state guidelines. I know, and again, because after those cases in Georgia and California from ferric sulfate pulpotomies, and it was really due to contaminated water lines that were iron loving, not ferric sulfate itself. I do not sterilize my cotton pellets because remember, your NeoPUTTY is alkalinized and has a bactericidal effect from its setting pH of 12. So no, and if you want to rock and roll, yeah, I know people who do that. They just take some of their cotton pellets, put it in a bag, and sterilize it. At the office that I work at, we have pulpotomy setups. So if you have separate trays and you have a pulpotomy tray, you can just pre-sterilize some of those packs and put them in your pulpotomy setup if you would love to, if you would like to use sterile pellets. The research is if you look at Jim Cole and Vinit's study, you don't really have to use any medicaments prior to doing this. But if you wanted to, you could use a chlorhexidine, like an endodontic solution, not Paradex. And you can find that from your dental distributor. I believe I don't use, we do a lot of root canals here, but we don't irrigate with chlorhexidine. So I apologize on off the top of my head. I don't know the exact dilution. Or I would use a sodium hypochlorite pellet. We use a 3% dilution. If you just use bleach, which I wouldn't recommend because every time we open that bottle, like the Clorox, it denatures from the oxidization. So I would use different syringes. And then we get those from Vista Apex. They're 3% sodium hypochlorite solution. And you can put pellets in there and if you want to with the sodium hypochlorite. If you're transitioning, you just want to make sure you're sterilizing everything. You could use a 3% sodium hypochlorite solution if you would like, or a formulated chlorhexidine.
Okay, perfect. We'll do maybe one or two more questions, and then, like I said, if you have any, keep sending them, and we'll do it offline. Answer your questions offline. The next one I have for your primary anteriors and canines, do you use the product for only coronal portion?
Ooh, this is a great question. Yeah. Ask me how I know. Yes, yeah. Yeah, thank you for asking that question. When I first started, so if you look at Vinit and Jim Cole's study, anterior pulpotomies actually had a better success rate than pulpectomies. And so what I do is I like that video, I take a little ball of it. I used to make it like hot dog style or long, and then I found that too much of that was getting down into the canal. So I actually just I put that in the orifice and I'll condense it with the cotton pellet. Yeah, we only really want that in the coronal 1/3 of the tooth. And we want to make sure that heme isn't seeping out. The hard thing with anterior pulpotomies is that whole tooth is pulp. We don't have a chamber where we're taking it down to smaller orifices. So I usually take my burr. Let me see if I have a good picture of. So if this is the tooth I'm doing the pulpotomy on and I remove the caries, I'll probably take it just below the CEJ and then I'll pack my cotton pellets. Sometimes you have to cut them a little bit, and then I'll go and do other things if I'm doing a more full mouth case. And then I'll take that cotton pellet out, and I want to see a nice little pooling or a blood clot there. And then I take my small amount of NeoPUTTY using the dispenser, a little less on an anterior tooth, and I pack it in with my cotton pellet like this. And I'm still making sure I would go in with a spoon to make sure about 360 I have clean margins prior to putting my buildup material. Yeah, so yeah, you just want to make sure, and if you're first starting to do anterior pulpotomies, take a post-op X-ray before. It'll just kind of help you show how you don't want to aggressively condense it because it will continue to go up the apex, and you might have to extract that tooth later because these materials don't dissolve. MTA is a permanent material. It doesn't dissolve as the permanent tooth comes in, so you might have to extract it later if you got a little too excited and went farther up the apex. But if you leave it in the coronal 1/3, you shouldn't have any problem exfoliating it.
Perfect. And this is going to be the last one. Once again, we'll answer all of your questions offline. So keep sending them in if you have them. But what is the difference between Paradex and the perio-specific chlorhexidine you mentioned as an option for primary pulp treatment before the NeoPUTTY? Do I need to say that again?
Yeah, yeah. So, and I'll look it up because we have some curious friends here, which is beautiful. I love that. So Paradex is a specific periodontal rinse um, that has a different percentage of chlorhexidine. An endodontic solution, and I'm looking it up right now. Sorry, Preston.
No, you're good.
The chlorhexidine, and then this is, if I can't find it right off the top of my head, I can look it up online. Um, and then again, this is just me being a ding dong and not remembering off the top of my head. 2%, that's what it is. Sorry, thank you. So in endodontic therapy, chlorhexidine is used as an irrigant at 2%. And then Paradex chlorhexidine solution, I think it's 0.12%. So you have to make sure that like you're actually getting, if I'm just putting Paradex in it, well, it might not be doing anything, as far as and again, I'll preface, I don't use any sort of medicament on my cotton pellets when I'm doing pulpotomies. But it's just the percentage of chlorhexidine that is in solution. That's the main difference. It's the percentage.
Also wanted to recommend if y'all upcoming webinars, we do have our mastering intraosseous injection techniques on our SOAN and Sleeper 1 coming up next Wednesday, the March 26th. We have also the intro to intraosseous injections Wednesday, April 9th. And then on Thursday, April 17th, we'll have mastering zirconia crowns. But other than that, I want to say thank you very much, Dr. Patrick Ruck. That was a great presentation, very engaging. I love the personality, and still the video of your son hitting the glass is it's awesome. But other than that, thank you everyone this evening for joining another New Smile webinar. If you have any questions or regarding New Smile products or anything of the upcoming webinars, feel free to reach out to myself. Once again, I'm Preston Fun to Know. Well, thank
Thanks,
you very
everybody.
much. Have a great evening.